About nasoseptal flap and CCF leakage, I agree completely with you. It's
Okay, good morning in Miami. We're televising the conference on neuroendoscopy from Uruguay. Estamos televisando un congreso de Uruguay y vamos a empezar.
grad 1.
Es día 4, day 4.
Fascia lata, it's enough, and we don't need nasoseptal flap. And what about your patient nasal quality of life when you do nasoseptal flap?
Nice. Thank you so much. Nice questions. I'm going to answer first the quality of life. We are performing 2 studies in our service nowadays. That one, it's about the quality of life, using a specific questionnaire to all the patients that it's doing this kind of surgery. And it's all categories that we have in the questionnaires. That is a SF36. It's improved. All the categories improved. So the patient improved the quality of life for sure that we have after 3 months. The first month decrease the quality of life, the third month, because we have done the questionnaires preoperative, 1 month, 3 months, and 6 months. With 3 months, improve the quality of life for sure. And we are performing the other study about the olfaction of this patient. The patients that are performing the nasoseptal flap. All the patients that are doing the nasoseptal flap, we are doing the Connecticut test. And after 3 months, improve again the olfaction of the patient. So decrease in the first month, they sometimes stay without olfaction, but with 3 months, return to the regular olfaction preoperative. About the nasoseptal flap, this is a very interesting and important question. Nowadays, the pituitary gland, you don't need to do the nasoseptal flap. Okay. Because, of course, it's not always that you have a CSF leak. So the nasoseptal flap, you have to use just when you have a CSF leak. So
and even when you have CCF leak, I think fascia lata and some fat, it's enough. I do more than 1,000 pituitary adenoma, and I never do nasoseptal flap.
I agree with you. But so when you are doing a pituitary surgery, you can do what we call rescue flap. That you do a bilateral rescue flap and you have a straight approach to the pituitary area. Just to complete this, I agree with you. You can use fascia lata when it's a small defect, or just to put a free graft in fascia lata. It's okay. It works very well. But remember that Professor Harvey from Australia, he published a systematic review in 2012 that he compared all the service that was not using pedicle flaps and the service that was using a pedicle flaps. And there was statistically significant that the service that was using the pedicle flaps was less CSF leak in the postoperative.
For what pathology?
For just a huge defect, huge. Okay. I don't remember now, but for example, more than 3 or 4 centimeters, something like that. Just with a CSF leak in the intraoperative. Yeah. But we know that a lot of service don't use. So it's really possible.
We are not talking about, but we work in Brazil in a public hospital, and the adenomas that we operate are huge, with huge intracranial extensions. Surgery many times.
Yeah.
That's why we are using so many flaps to close. Almost as a routine. Yeah.
This percranial flap was developed by Zanation, correct?
Yeah, exactly. Yeah, perfect. Yeah, but was published by Professor Carral in 1990. But it was a standard approach for head and neck surgery. And in 2008, Zanation was made, or 2011, I'm not sure. he made this published, that this article was published, but he was doing all the surgery by endoscope, just with a small incision. We are doing like a mix of both, you know, with a big incision and through the nose with this small window. He was doing just some incisions here and there. So,
meningioma. You can do it by transcranial approach also.
but you don't do the retraction, yeah?
Yeah.
Yeah. This is the point. We think that this is the point.
Yeah.
That we think that there are many ways to do different kinds of surgery, and it's difficult to say what is better. I think what is better, it's what your team it's more used to, and what is better for the patient. So
yeah.
In this case, it's working very well.
Yeah, for middle fossa, I agree completely, but we can discuss a long time about
exactly. I totally agree. Yeah.
Yeah. I agree.
And the other idea that Professor Americo said, when you do like below, you can do like a Simpson one and do the ligation of the anterior and posterior ethmoidal arteries. That this is very interesting too. That have less bleeding. Yeah.
Perhaps despite a huge treatment of the CSF leaks, with all of the approaches, that you have a case that you have the leaks persist, perhaps instead of the treatment, because it's very interesting. Sometimes, despite a huge approach, huge flaps, it's possible to put near to the. If it's possible to identify the leaks persist instead the treatment. And it's necessary to put a shunt sometimes. You have some cases, one case or two cases. I have one that is very difficult to solve actually.
We can identify the CSF leak and not too close. Yeah. I remember to have a case that the patient had many jobs. You cannot identify a CSF leak. You have made different ways to try to identify, like to put a fluorescein on the back, try to see on the nose. It's not that true. Spontaneous CSF leak was really operated 3 or 4 times.
Yeah, this is the case.
But not our service.
Yes, but the anti-site group is
yeah.
It was something like this. The only way that we managed to close this.
But in my opinion, in this case, the surgery was made in other service. I think the approach was not the best one. I think the best one approach to that case was to do a transperidural approach, because you can see here that was very easy to identify the defect. Perfect. And when we identified in this case the defect, we talked about why not just to put a bone and some. So do you remember it? It's not so huge. Just to put a bone and mucosa, some storage seal. We started to think, but the patient said, "Please, doctor, help me. I don't want to have more meningitis and CSF leaks. I work with my head looking down, and I have to be good to do my work very well." So we said, okay, we talked with her, we said that the surgery would be a huge surgery. So we said, okay, let's go to do this huge flap for this small defect. I totally agree. We said, oh, you can close just with mucosa, first flap. Yeah, I totally agree. Or choose a lateral flap. This is another alternative for this case. Never.
Okay, I congratulate America and your team. This is a very nice team to work in this field. Congratulations. Thanks so much.
So good morning to everyone. I'm very happy to be here. Thanks, Professor Cordova, for the invitation. I would like to go quickly through some controversies existing in tuberculum cella meningioma, as we discussed before. So one of the problem with tuberculum cella meningioma is the fact that if you go through all papers existing in the literature and case series, there is always a mix between tuberculum cella meningiomas, planum sphenoidale meningiomas, olfactory groove, diaphragma cellae meningioma, and this created a little bit of confusion in interpretation of the results because they are effectively different tumors and the results are also different. The problem started with this classification in 1930, created by Cushing, because he named this meningioma supracellular meningiomas, which was correct for the time because he didn't have the MRI, and so we can understand. But supracellular meningiomas is a term which is a little bit large and includes also sphenoidal meningiomas, so which are different tumors to treat, of course, if we compare it to tuberculum cella meningiomas. Then, for his time, is also understand that there were different types of tumor, depressing the chiasma or elevating the chiasma, and that there were different categories, but he wasn't able to properly distinguish for that time. Then Yazagi created this classification, which is also about only dimension. Dimensions is an important criteria, but there is a lack of description of the neurovascular encasement, which is one of the most important things and difficult in this kind of surgery. Then Goel created another very complex classification, which wasn't really used in the literature later. And then we arrived to Shikar-Mortazavi classification, which is really easy to use. It goes straight to the point. You should consider sites, optical canal invasion, vascular encasement, brain invasion, if you see two FLAIR images, and if the patient had previous radiation or previous surgery. This is an easy classification to use, which can be used also to understand what patient can be treated with endoscopy or transcranial surgery, as the authors claimed. There are some controversies, of course. First of all, there is a necessity of doing a routine endocrinological examination from this kind of patient. Craniotomy, side of craniotomy, you should open the optic canal or not. When should you do that? Should we open the Sylvian fissure? Should we treat this patient by an endoscopic way? If you go to endocrine function, this is very varied in the literature. There are some papers that claimed no preoperative and no postoperative endocrinological deficit, and other studying better this thematic, underlying that you could have postoperative endocrine deficit. There is a high rate of diabetes insipidus. So probably we should study better and we should perform routine endocrinological examination and also follow the patient in the postoperative phase from this point of view. About the craniotomy, all the approaches are described in the literature. You can do tyrannial approach, unilateral, subfrontal, bilateral, subfrontal, interhemispheric. All the authors describe very good results, but it's probably nowadays a better approach to perform only unilateral craniotomy and avoid bilateral because of contusion, the risk of bilateral contusion, and the risk in transecting veins draining to the sagittal sinus, creating possible venous infarction, as described by Sami in this paper. About the side to choose for craniotomy, there are some authors who decided to approach the tumor always from the non-dominant hemisphere, which is not very used and described in the literature. This is an interesting paper describing that if you perform a contralateral approach, it's better to have visualization of the inferior part of the optic nerve, which is usually a blind area of dissection when you perform monolateral the approach from the side where vision is worse. So there is some advantage, the fact that you can really control this area, which is normally not very well seen with homolateral approach, but you can you have a risk of damaging the functioning optic nerve, and then you have difficulties in dissecting the part of the tumor which is lateral to optic nerve and carotid artery. Most of authors decided to approach a tumor from the side where vision is worse, where there is optic canal invasion, as we did in our department. A lot of authors do that, Ernest Niemi and colleagues too, and the logic is to preserve the non-compromised optic nerve. So probably it's the better choice. There are some authors claiming that it is important to perform a large opening of sylvian fissure, making that in the end a transsylvian pteronal approach, which obtain good results, but most of authors are more focused on skull-based approach without needing of opening the sylvian fissure, and they obtain very good results in terms of visual improvement, no visual deterioration, without all the complication linked to a large opening of sylvian fissure and vascular problems. So probably it's better to avoid perform a large opening of sylvian fissure. Opening of optic canal, very controversial point. There are some authors who described and obtained very good results in terms of vision without the need of performing always a routine opening of optic canal, saying that it is effectively not necessary to perform aggressive skull-based approach, but their results should be, of course, compared to other authors, Mathiesen, Mortazavi. We obtain very good results with aggressive skull-based tumor, skull-based approach, extradural cranioidectomy, early release of optic nerve, ALMFT, of course. So generally, if you go through the literature, the result seems to be better when you perform an effective skull-based approach and you go on to decompress the optic nerve in an early phase of surgery to relieve compression and avoid traumatization of the nerve during tumor resection. There are some also authors who perform the resection of the tumor, the debulking, and then they go at the end of surgery to explore the optic canal and decompress the nerve. The results are good too, so it's very difficult to obtain a clear understanding of this point. Extended endonasal approach is this paper from the group of Schwarz. They claim very good results with endonasal surgery, especially in terms of visual improvement and effectively a lower rates of brain traumatization and epileptical crisis. Then there is this review of the literature who go through tuberculum cella, olfactory group, planum meningiomas. Effectively, the results in terms of improvement of vision were slightly better with endoscopic approach, but there were, of course, more CSF leak, which then decreased with the development of gasket seal technique and nasoseptal flap. The group of Gentili tried to show some criteria to select the cases that could be treated with endoscopy. So they say that normally if there is a big extension of the tumor lateral to ICA and optic nerve, there should be some difficulty in resecting this part with endoscopic surgery. For them, if there is a major neurovascular encasement, it is a formal contraindication. And then, of course, you should take in mind all the complications linked to a possibility of postoperative CSF leak, which still is higher when compared to transcranial surgery. In the end, what my colleague was talking about is nasal quality of life. So in this paper, Schwarz analyzed the quality of life of the patient treated endoscopically with meningioma and the nasal quality of life. Of course, if you talk about adenoma, there is no big issue in nasal quality of life, but when you start doing meningioma and you drill all the skull base, the nasal quality of life is worse, clearly worse. So this is not very well studied in all the endoscopy paper. This is the last paper of the group of Naples, which is more towards endoscopy surgery, and California towards transcranial surgery. They created this nice classification, very easy to use, taking in consideration size, optic canal invasion, and vascular encasement. And they analyzed their results retrospectively. Finally, in the end, there was no big difference. The cases with major points, means bigger tumor, vascular encasements, were generally treated more with transcranial surgery. But in the end, the results in terms of visual improvement, in terms of CSF leak, they were not so different. So conclusion, it probably depends a lot on the surgeon experience and preference. This is our series of cases. We analyze our results according to the CCAR-Mortazavi tumor classification. So half of patients were class 1, so most easy cases to treat, and last 50% class 2 and class 3. 80% of patients presented with visual preoperative impairment. I would like just show a video. So a patient of 63 years old presenting with visual impairment, so left frontotemporal craniotomy, very basal approach. If you see, there is almost no need of brain retraction. It is a retractor-less surgery. There is a progressive vascularization of the tumor. You see here optic nerve, carotid artery. This is the part lateral to carotid artery, which is difficult to address with endoscopy. Will limit the use of bipolar coagulation, so it is almost dissection surgery, avoiding at possible the use of bipolar. This is the progressive exeresis of the tumor. The bulking, you see contralateral optic nerve and carotid artery. And then this is the postoperative MRI with complete resection, and this is the visual improvement 3 months after surgery. Okay, so the results for us, we choose always the side of the most major optic nerve involvement. Basal frontotemporal craniotomy with orbitotomy to reduce brain retraction. Cranioidectomy only for selected cases. Lateral subfrontal approach, opening of the severe fistula only as needed and proximal. The results, gross total resection, 93% of the patients. No patient experienced visual deterioration after surgery, which is quite good. Improvement, 78% in class 1 tumor and 67% in class 2 and 3. Cranial nerve deficit, 2 patients experiencing anosmia, 1 patient with a 4th cranial nerve, and partial anterior epitreatis, 1% of the patients. In conclusion, for tuberculum cell meningioma, we still support transcranial approach. It is very important to perform a careful visual status examination and imaging, and we could still obtain excellent visual outcome and also good tumor control rate with transcranial approach with minimal morbidity. Thank you very much for the attention. This is the follow-up of something like 3-4 years in this paper. Transcranial surgery, transcranial approach. If you pay attention.
Watertight closure.
Very tight closure.
Watertight closure, right?
Tight closure, it means that you just mean dural tight closure, plastic, glue if needed, good sealing of the frontal sinus if you have, if you open that with the pericranial flap, glue, and all this stuff.
Nice work.
I think that you brought a non-dogmatic way of looking to this pathology, and I enjoyed your position. Perhaps we should understand that tumors in this anterior cranial base, especially meningiomas, they're not tuberculum meningiomas. They might be tuberculum plus optic canal and plus planus sphenoidale. The ones in the planus sphenoidale might go anterior, may go posterior. So we cannot say that they're pure from one region. We have to consider that even though there is some distance, those tumors are superficial. And always we think on endoscopy, we think on deep structures, because we're not able, if a meningioma has a large base, it's not easy endoscopically to see all the area of implantation of this meningioma. More than this, if you have even in larger anterior base meningiomas, they may arise in one side of the cubiform plate and then move to the other side. And if you look carefully in the two-weighted you can remove those tumors, avoiding damage to the contralateral olfactory nerve and then preserving function of olfaction. And every time I think on endoscopic approaches to this anterior base tumors, I think that for all the reasons you pointed out, I would prefer to go intracranial and use endoscopes as necessary if they can be used in the intracranial approach instead of going endonasal. Tuberculum cellular meningiomas would be the ones that we would mostly think on doing endonasal. But even though especially if there is some invasion of the optic canal and it's over the nerve, I would prefer, for sure, come from intracranial approach. And then when you use endonasal approach, if you do intracranial, may have a smaller craniotomy than doing endonasal. And then we can go there, and if it's necessary, because the implantation goes lower in the anterior pituitary area, then we can use the scopes and have this portion of tumor taken endoscopically. But we have to take off this confusion between technique and approach. We can do endonasal with the microscope and with the endoscope. We can do intracranial with the microscope and the endoscope. So two different things. And sometimes we try to be religious in saying, well, we have to do endoscope, we'll have to do endoscopically. Probably we should tailor the situation for each patient we're seeing And what's the purpose of surgery? We want just to decompress optic nerves. This patient is old. We don't want to go through a thorough resection. Perhaps we should think a bit on how to decide to operate those cases. I think you brought a very interesting point of view.
Thank you. I agree with you about the reflection about the fact that tuberculous cell meningioma, they are not always strictly midline lesion. There is some paper demonstrating that the origin is, in most of cases, unilateral. So it makes sense what you told about the preservation of action. And then about the fact that nowadays, to perform and obtain always a Simpson grade 1 with radiosurgery and all this stuff, doesn't make the sense that he made in the 80s. So to perform always a grade 1 Simpsons 1 in meningioma is a concept that has been evolving, that should evolve, because there are some meningiomas that tends to evolve a lot, but is 75% of meningioma which behaves in a different way. So I think that the truth is in the middle. We should tailor. Maybe there are some good indication for endoscopy. It's something intriguing, but there's still some big controversial in my mind.
I think that Simpson still is valid. You see, we must try always to have this in mind. Many times it's not worth to do a Simpson one, but our goal is always Simpson one. If you have a maybe 80 years old patient, doesn't matter if you're doing Simpson 1 or Simpson 2, but if you have a 30-year-old patient, it really matters. It really matters. I try not to have like Alan Castro, I try not to have a dogmatic view. We do a lot of craniotomies, especially a supraorbital keyhole approach for many meningiomas. There are a lot of questions, for example, nasal anatomy, patient with a conchal sinus. I'm not going to do this endonasal. I'm going to waste my time there and be much more aggressive than doing via craniotomy. Yeah, but you showed us a very nice surgery, very nice technique, and I fully agree with most of what you said. Thank you.
Thank you.
We have a break now for half an hour. Thank you.
Testing 1 2, testing 1 2, testing 1 2. Testing 1 2. Testing 1 2, testing 1 2. Testing 1 2. Hi, I'm Dr. Bennett from Miami Beach. Estamos esperando para la pieza de este Congreso. We're waiting for the beginning of the Congress. I believe it's starting.
Que lo moví. Ahí está, que lo moví. Oh, sí. Lo enderezo mejor. Porque yo creo que está todo doblado. Del otro.
Pero eso es, no es distinto lo que digo yo.
No tengo. Pero sí, sí veía, sí, claro. Sí. Pero sí ve que abrió.
Abrió recién, ¿eh?
Sí, pero no, ahora no.
Ahí va.
Las pantallas.
Ya, vamos a ver, ya.
Sí.
Sí, tengo mucho.
Yo aquí, perdón, aquí en la
Vamos a continuar con la actividad, ya último tramo del sexto congreso. Antes de dar paso a la próxima conferencia, aclaraciones. El programa contenía, para lo que era el inicio, varias conferencias que no pudieron realizarse por diferentes motivos. Por motivos laborales, el profesor David Locatelli, y por motivos de salud de su madre, lamentablemente un accidente vascular que lo ha retenido en Grecia al doctor Spiros Esgouros, por lo tanto, situaciones comprensibles que no hemos podido completar la actividad que estaba prevista. Sí, damos paso a lo que es la presentación de trabajos, y la presentación de trabajos, inicialmente, los recibidos en nuestra web, eran múltiples trabajos, pero no se presentaron al Congreso y por ende imposible la presentación, varios de ellos, y por eso, en este caso, más allá de estos problemas técnicos que estamos teniendo, las felicitaciones a la doctora Victoria Ronquillo de Guayaquil, Ecuador, por sí habernos acompañado y haber sido una de las primeras en enviarnos su abstract para la presentación de este trabajo. Unos minutos más y entonces damos paso a la conferencia.
Okay, folks, standing by from Uruguay. I don't know if we lost the signal or what. I haven't lost the signal. I still have the signal. We have one more presentation before the conference ends. And then I hopefully will be able to have a short chat with Alvaro Cordoba, the neurosurgeon artist. I hope we can get him on.
La presentación de este caso, ¿no? ¿Verdad? Yo vengo de Guayaquil, Ecuador, trabajo en un hospital pediátrico desde hace 18 años. Hacemos procedimientos endoscópicos desde el 2002-2003, ¿sí? Tenemos más experiencia, pues, como hospital pediátrico. La primera opción de manejo endoscópico son las tercerventriculostomías, causas principalmente posttumorales, hacemos en otras causas congénitas, hemos hecho también en niños con malformaciones congénitas mielomeningocele, hidrocefalia, menos casos, pero intentamos hacer cada vez más por todo lo que sabemos versus la colocación de una válvula, ¿no verdad? Hemos hecho muchos procedimientos endoscópicos, en todo caso, pues yo, como ustedes saben, uno a rato entra con un endoscopio y muchas veces se encuentra cosas que en realidad no esperaba verlas y finalmente en base a lo que vimos vamos a revisar finalmente qué es lo que hice y qué fue lo que encontré, qué patología, qué quiste, etcétera, ¿sí? Bueno, entonces a propósito de una... una niña de 9 años que luego de haber presentado un trauma de cráneo no muy importante, comienza con cefaleas, ¿sí? Pero al revisar a esta niña, ella ya tenía unos antecedentes personales con cefaleas, un retraso motriz, veíamos a los 8 años un perímetro cefálico por encima del esperado a una niña de esa edad, tenía trastornos visuales, tenía una ataxia de la marcha, una serie de manifestaciones, pues que ya el neurólogo, el neurocirujano las reconoce efectivamente, ¿no? Entonces se le hace una resonancia de cerebro y como ustedes, una tomografía de cerebro, y como ustedes ven, pues una tomografía simple, una gran área hipodensa a nivel de la cisterna cerebral, supracelular, una hidrocefalia severa, ¿sí? La imagen que a nivel de con un tercero grande, la imagen clásica de Mickey Mouse, ¿sí? En una con contraste, tomografía que no vemos mayor cambio, mayor realce, la resonancia de cerebro, como ustedes ven, una densidad de una lesión, densidad de tipo líquido cefalorraquídeo en un T1, un quiste celular, supracelular, preprotuberancial, como desplaza protuberancia y mesencéfalo hacia atrás, ¿sí? Entonces, aquí lo mismo en unas imágenes en T2 para ver la relación también con estos quistes aranoideos, subtemporales, bilaterales. Entonces, lo que se propuso fue realizar un abordaje evidentemente endoscópico para realizar una tercer ventriculostomía endoscópica, ¿sí? Probablemente ver un quiste a nivel del tercer ventrículo. Entonces, a través de un trépano, un agujero de un trépano a nivel de punto de Kocher, frontal derecho, entramos. Entonces sí, vimos un gran quiste dentro del tercer ventrículo, obstruía Monro de los dos lados. Por su hidrocefalia severa, vimos una fenestración espontánea del septum. Entonces entramos y mediante un coagulador monopolar, fuimos a coagular esta cápsula de este quiste, el domo de este quiste, una cápsula muy firme, muy gruesa, muy difícil de perforar, de fenestrar. Hubo que hacer muchos intentos en varias zonas, como ustedes ven, y al mismo tiempo se trató de retraer el domo de este quiste. Muchos intentos, ventajosamente, a pesar de la presión que se hacía, pues, que no es lo recomendable, no se produjeron sangrados, ¿no verdad? Hasta que finalmente pudimos perforarla y luego se introduce un balón Fogarty, pero sí ven que debajo de la membrana gruesa hay una pared fina, ¿no verdad? Como un epéndimo. Entonces sigue lo mismo, no fue suficiente la coagulación inicial, pero se pudo introducir el Fogarty, una sonda Fogarty de Don Friends, se lo dilató, y vemos cómo ya se deprime un poco, se fenestra, se comunica. Entonces hicimos una ventriculocistostomía, vemos ya las estructuras a nivel dorso de la silla, fuimos hacia el lado derecho, cómo se ve ya la fosa temporal. Este es el borde libre del tentorio. Entonces vimos otra membrana más que me impresionaba, como ya cisternas silviana, ¿no? Parte del quiste temporal. Entonces igual se lo fenestra con la pinza, una membrana muy finita ya en este caso, sí, pues membranas aranoideas finas, se las fenestra, se permite con facilidad. se dilata, introducimos la sonda Fogarty, se dilata a sí mismo con facilidad. Entonces, está indicado entonces en estos quistes celares, supracelares, prepontinos, a más de realizar aquí vemos, como ustedes pueden ver, la arteria basilar. Entonces se trata evidentemente de la cisterna prepontina. Entonces, y ahí podemos ver ya, hacemos un retiro un poco y vemos todas las estructuras, el tronco cerebral, protuberancia, vemos el sexto pare, vemos el borde libre de la tienda, acá fosa temporal de un lado. Bueno, entonces como vemos, pudimos realizar una ventrículo cisternostomía, luego pudimos coagular un poco más y tratar de retraer. Aquí vemos el septum fenestrado, comunicación lado derecho con el izquierdo, espontáneamente, como sabemos en estas hidrocefalias severas. Entonces, hubo mejoría clínica de la niña, sobre todo de la cefalea, y en las imágenes esto es prequirúrgico, esto es posquirúrgico, vimos más surcos, el quiste disminuyó de tamaño, acá vemos menos retropulsión sobre la protuberancia y sobre el mesencéfalo. Entonces, como ya les dije, lo que se hizo, entonces, pues los quistes aranoides, como sabemos, pueden localizarse a cualquier lugar del eje cráneo-espinal donde existen aranoides, incluso dentro de los ventrículos. Pues se dividen en supratentoriales, infratentoriales, supra e infratentoriales. Vemos que supratentoriales, más frecuente, fosa media, también hay interhemisféricos de la convexidad, interhemisféricos de la región celar, intraventriculares. Muchos hay de las cisternas cuadrigeminales y ambis que se extienden hacia el tercer ventrículo. Existen muchas series, mucho se habla de estos quistes, a veces se los reporta como a los localizados a nivel supracelular, cisterna prepontina, que representan del 5 hasta el 12.5%, y cuando va a poblaciones pediátricas hasta el 16%. Otros los reportan como solamente quistes supracelares, que la incidencia es muy baja, un 1%. O como quistes intraventriculares, ahí está más amplio, implica del tercer ventrículo, de los ventrículos laterales, hablan de un 0,5 o un 2%. En cuanto a la formación de estos quistes supracelares, se sabe de que surgen de una anomalía de la porción diencefálica de la membrana de Lilliken. Su formación en la etapa embrionaria no es muy clara, a diferencia de los quistes de la cisterna silviana, quistes de fosa posterior. Para entender esto, acerca de cómo se forma este quiste y tiene tantas extensiones, pues hay que atender la anatomía de la cisterna interpeduncular, de la membrana de Lilliken. Pues Fushimi la denomina como un complejo aranoide lobulado con un componente diencefálico, mesencefálico y un componente celar, ¿ya? En donde la membrana de Lilliken, sabemos que está formada por estas dos hojas, se extiende hacia anterior, hacia la cisterna quiasmática, sobre el proceso clinoideo posterior, sobre el dorso de la silla, y se extiende hacia anterior, y en forma intersegmentaria se extiende hasta los nervios oculomotores, ¿sí? Por su lado, la membrana, la cisterna interpeduncular, va entonces desde los pedúnculos cerebrales hacia la membrana de Lilliken, hasta estas dos hojas de la membrana de Lilliken. En todo caso, pues considero que la expansión de este quiste de gran tamaño de alguna forma se comunicó y se extendió parte del mismo complejo hacia las cisternas silvianas, en la aplicación que yo encuentro. Entonces, sea que se forman como un divertículo o como una división de esta membrana de Lilliken, entonces posteriormente hay un incremento por la secreción de las otras teorías de por qué crecen estos líquidos, ¿no? Y podrían estar comunicados o no con las cisternas de la región. Aquí es lo mismo. Entonces, la discusión va en qué procedimiento realizar, porque la frecuencia en estos quistes está reportado de que pues recidivan, reaparecen de nuevo los síntomas porque pues se ocluyen las fenestras, ¿no verdad? factores en relación a que se ocluyen, en relación a qué procedimiento se hizo. Si solamente se hizo la fenestración apical del domo del quiste, entonces esto hace que no fluya líquido hacia las cisternas. Entonces, se conoce de que es suficiente hacer una ventriculocistostomía si vemos que si hay una comunicación con las cisternas de la base, y se lo puede determinar mediante la realización de una cisternografía por tomografía o por resonancia, ¿no? Entonces, si es que hay la presencia y el paso del medio de contraste hacia el quiste, se dice no hacerlo, ¿no? Se puede observar durante la cirugía también, además de comprobarlo por la cisternografía, la presencia de una hendidura, un poro alrededor de donde la arteria basilar penetra la cisterna, ¿sí? O de lo contrario, si vemos que no hay el paso del medio de contraste, no hay el poro alrededor de la basilar, entonces se recomienda hacer una ventriculocistocisternostomía, ¿no? Claro, otros están en contra porque pues es peligroso entrar a hacer la perforación de la cisterna prepontina por la presencia de la basilar, la presencia de los nervios oculomotores, etcétera, pero pues si se conoce la área, se sabe la anatomía, pues no hay problema. Muchos pueden colocando un stent en la fenestración de la cisterna para evitar la oclusión del quiste y posterior cicatrización sobre ella misma. Tenemos... aquí se reporta, sí, pues no encontré el reporte de este quiste, de esta ubicación con componentes sobre la cisterna silviana. Hay un reporte de un caso, sí, que se comunica hacia o sea, que tiene un componente relacionado hacia la cisterna silviana. Otra discusión es en cuanto a por qué igual la oclusión de la fenestración. Porque la misma pared del quiste, el domo del quiste, se puede ocluir porque el tercer ventrículo tan dilatado finalmente se colapsa sobre sí mismo, ¿sí? Tanto tiempo dilatado, porque también el quiste puede ocluir la parte posterior del acueducto de Silvio. La misma fenestración, un quiste redundante, puede ocluir posteriormente si es que no estaba previamente ya ocluido, puede ocluir el acueducto de Silvio, entonces es una causa de que recidiven. Entonces, ¿cómo se evita una recidiva? Pues se refiere a hacer una reducción total del domo del quiste mediante la coagulación y contracción de este, ¿sí? Entonces, aquí se refiere entonces coagulación para contraer la pared superior del quiste y evitar recidivas. Otros factores en relación a por qué recidivan es en cuanto a la amplitud de la fenestración de la cisternostomía, que si se hace con un Fogarty, si se hace con tijeras, con pinzas de biopsia, con láser, no, porque sabemos sobre sobre las estructuras que estamos actuando. Entonces, en sí, se sabe que la apertura debe ir más allá de 1 a 1.5 centímetros, ¿ya? Porque se puede cerrar por la baja presión que existe a nivel de la pared del quiste, ¿no? Entonces, se recomienda la coagulación de la porción rostral de la pared del quiste para contraerla, ya que al quedar flotante y redundante puede ocurrir la ostomía. Los quistes aranoides supracelares precontinuos pueden ser tratados mediante ventriculocistostomía o ventriculocistocisternostomía con estas observaciones, ¿no? Muchos refieren los mismos resultados, no son significativos hacerlo uno o lo otro cuando hay la evidencia o no de esta hendidura, de este poro en los estudios, sea por imágenes, cisternografía o por quirúrgico, ¿no? Pero en general comentan que la ventriculocistocisternostomía muestra mejores resultados que la ventriculocistostomía. No encontré, como les dije, reportes de casos similares asociados a quistes aranoides, de quistes aranoides supracelares asociados a quistes silvianos bilaterales. Entonces, además de las denominaciones ya conocidas de estos quistes, se debería mencionarlos como yo del tercer ventrículo, porque evidentemente estaban dentro del tercer ventrículo y no los encuentro reportados así. Entonces se debería realizar una ventriculocisternostomía en todos los pacientes con quistes aranoides supracelares para prevenir la recurrencia del quiste. Se requiere controles a corto y a largo plazo, tanto clínicos y de imágenes, por la posibilidad de cierre de las fenestraciones. Los síntomas pueden recurrir luego de muchos años en una u otra técnica. Bueno, esto es todo. Gracias por su atención. Y les invito, pues en el 2020 Guayaquil ganó la sede para el CLAN, ¿sí? El CLAN iba a ser a partir del 16 de noviembre del 2020. Gracias.
Supracelular con un quiste aranoideo bilateral, incluso a nivel temporal. Y la bibliografía así lo demuestra, o sea que obviamente no, la resolución fue exactamente así. La discusión, lo que usted ha dicho, es justamente de tratar de fenestrar la base del quiste, que es un poco la parte más riesgosa en relación a la proximidad del tronco, en el sentido de asegurar la correcta comunicación. Lo otro es lo que hablaba el profesor Ertel ayer, del uso o no de la cistanografía en cuanto a todo lo que es prohibitivo en ese sentido, por el abordaje intratecal que se hace con la resonancia, con la punción y todo eso. Y también muchas veces la comunicación con la cistanografía no significa que la comunicación sea correcta, sino que sí existe un flujo, pero no tenemos forma de medir si ese flujo es exacto, por lo cual incluso podría agrandarse esa comunicación para que el flujo sea mayor y el quiste pueda mejorar. Lo otro es la aparición de surcos en la convexidad, que es importante en la reducción de la presión dentro de la cavidad, de la parte intracerebral, y esperar con mucho tiempo la posibilidad de resolución de la imagenología, lo cual lleva muchos meses o a veces años. ¿Algún comentario, los colegas?
Interna prepuntina es porque la membrana del helicoíste puede estar duplicada y haber una otra barrera al flujo licúrico, como hablaba Álvaro. Entonces creo que mismo que no se tenga un quiste obvio, prepontino o supracelular, es necesario en los quistes temporales estudiar muy bien la posibilidad de haber otras membranas que no van a permitir que la cirugía de fenestración del quiste temporal, de la cisterna temporal con la cisterna prepontino prepeduncular tenga el efecto que deseamos. Entonces, cuando esto ocurre, pensamos en hacer la fenestración del quiste temporal y la tercera ventriculostomía con la fenestración de la membrana del helicoíste, porque no se logra hacer en un único procedimiento las dos aberturas, ¿no? Pero estás con este caso a comprobar que existe la posibilidad de los dos quistes o que sea en verdad un quiste único que comunícase, ¿no? La extensión del quiste supracelular se hace al lado en dirección en la cisterna silviana, dando la impresión de que el quiste original sea silviano.
Penetration of the supracellular cyst perhaps in combination with temporal cyst sometimes. You prefer perhaps to do the fenestration at the upper part of the system, to combine the lower part with the system?
Fenestration, only one side is not working. Unless you combine it with a double fenestration at the bottom of the cyst and ETV, but the floor third ventricle at this point is very, very low. Unless you do it, it doesn't work. Those patients have high failure rate if we do not do aggressive fenestrations. And I had a patient one time who excellent fenestration, and at the end he needed a shunt. He developed 6-nerve palsy, and they just have a pressure problem. Even when you do fenestration, they still need a shunt.
Because you are changing the pressure values inside of the system, suddenly goes to the system. But normally increase the pressure suddenly for a few days, and you have to wait for the equilibrium to take place.
And those patients can benefit, like Pepe Cinelli described it. If you have a patient who you do fenestrations and ETV and they're still symptomatic for a few days, doing few lumbar punctures can it will do two things. A, will temporize, will take pressure away from the ventricle, and second will lower the gradient, CSF gradient in the pre-Pontine cistern from taking too much fluid from below. And this can make the ETV actually has a better flow.
Y tal vez para expander sobre ese último comentario que hizo Samer, una de las tácticas o de los tips que aprendí de uno de mis maestros es que estas punciones lumbares que hacemos para los pacientes post tercer ventrículo, nosotros jocosamente en mi hospital decimos que hacemos la punción del pediatra. Pedimos una aguja 18, la rosada, y entonces hacemos múltiples perforaciones en la dura, ¿no? Lo dejamos como si fuera un salero para que se haga una fístula temporal. Y por ahí entonces se alivia un poco la presión. Habitualmente dura unas 24, 48 horas y se puede repetir según sea necesario, en vez de una sola punción evacuatriz, ¿verdad? Entonces, ahí les dejo ese tip de la punción del pediatra. Yes. Actually, back in Chicago, Pat told me this little trick. We do what we call the pediatrician's lumbar tap. So basically, you ask for an 18-bore spinal needle. Once you enter the thecal sac, then you go around and do a bunch of holes. You basically leave it like, you know, so it's multiple fenestrations of the lumbar thecal sac. It will usually create like a fistula that will last probably around 24, 48 hours, and you can repeat it. So that's even better than just, you know, just tapping the dura. It's a temporal fistula. Yes. Yes.
Bien, ¿algún comentario más? Tendremos una segunda presentación que no ha concurrido en la presentación libre. Por lo cual llega el momento de lograr el cierre, triste cierre del Congreso, agradeciendo realmente toda la participación. En estos días han sido muy intensos para todos y creo que hemos logrado en conjunto un excelente nivel de exposiciones. Felicitar a todos los colegas por la participación, de los hispanoparlantes y los no hispanoparlantes, los colegas extranjeros, y felicitar primeramente, bueno, que el próximo congreso se haga en la República Argentina con los colegas del Garrahan, a los colegas brasileños, a los colegas ecuatorianos, colombianos, a los colegas extranjeros del resto de Europa y Estados Unidos, muy agradecidos por todo, a los colegas uruguayos residentes que van a continuar el trayecto de endoscopía seguramente en el futuro, con mucho entusiasmo, a los colegas técnicos, a los colegas organizadores, realmente más que agradecidos, y bueno, esperemos encontrarnos seguramente. Anualmente tratamos de organizar siempre un workshop en Uruguay, la parte neuroendoscópica. El año que viene intentaremos hacer el esfuerzo y tratar de continuar esa actividad. Creo que hoy vienen buenos tiempos en la Federación Internacional, con la presidencia del profesor Schroeder a partir del año que viene, que es un entusiasta en todas las actividades docentes, y lo que podamos continuar después de 2 años en adelante, en lo personal, con mucho gusto. Gracias de nuevo, un gran abrazo y seguimos en contacto.
No pude, ¿cómo le hago para eliminarse? Gracias, doctor, gracias.
Hola, Gerardo. ¿Está Álvaro? ¿Puede hablar con Álvaro? Gerardo. Shut off. Whoa. Hello, anybody there? I would like to talk to Álvaro. Hello, Gerardo? Hello, testing, 1, 2. Gerardo, can you hear me? Hello, testing. Can you hear me? Gerardo? 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 Yeah, there you go. You got it. You got your camera now.
A ver, sentate, Evelyn.
You got the camera now, right? Oh, excellent, excellent. You see my studio?
John, ¿me escucha, John?
Sí, yo puedo escuchar.
Ok. Quiero... Siéntate ahí, siéntate ahí. Ahora se lo pongo, se lo pongo.
Perfecto. Hey, Warlex. Unmute.
Hi.
How are you doing?
I'm okay.
Well, okay. We're at the end of the conference now in Uruguay, and I'm just doing interviews with the neurosurgeons, and you can ask questions too on endoscopy, neuroendoscopy, okay?
Okay.
Some of the questions will be in Spanish, but some will be in English too. And I want you to meet this neurosurgeon because he's an expert guitarist. He plays the guitar, classical guitar.
Okay.
He's not just like he plays something. No, he's a trained classical guitarist. And I'll give you his name and links to where his music is at.
Okay.
You guys could form a little band.
Yeah, right.
Yeah, we televised. It was a good conference, but the thing is, there's not many neurosurgeons around during the day. You know.
Yeah.
Yeah, they're working, so they don't have a chance to really. But it's taped it. We really need to get an editor. But Jesus, Warlocks, I'm going to China to speak to them about Chinese neurosurgical education. I don't know what the hell I'm doing.
It's a good chance. You should take that. You have an opportunity.
Yeah, it's a good opportunity. Well, we'll see what happens. The big thing is that if they'll back me, if the hospital will back me, and get other people to work with me, get computers, get it all. You know what I mean?
Yeah. So why they starting?
I'm getting the background. Hey, let me mute him. Hold on. Go ahead again, Warlocks. Let me. Go ahead.
So the medical school that you are going to work with, what things that make them interesting in your?
Well, Yuha is there. That's the main reason. I would go to the moon if he was on the moon. But they attracted him to head the department, and I work with him in Nepal for 3 months, and he really believes in this technology as far as teaching. Because he's a dedicated teacher. He wants to teach the rest of his life. He is so, I'm sure you know neurosurgeons like that. That's his life. He loves it. And you'll see when you meet him.
So which means that they already have a plan for you.
Well, because I said to Yuha, look, you want to do some presentations? And then, and he says, yeah, we're going to get that together. Well, I said, well, look, why don't we get the Chinese neurosurgical community together? Why don't we try to do that? And he said, how'd you know our plans? So they may have had those plans before they met me. Do you know what I mean?
Yeah. I got it. So maybe
but I think I'll give them a valuable tool to use. So.
John?
Yes.
John, can you hear me?
Yes, I can.
Okay. Can you listen to me from here?
Yeah, I see you. Yeah, perfect.
Can you hear me?
Yes, I can hear you well.
Okay.
Okay, Warlocks, I'll introduce you first, okay? You may be able to interview a couple of people.
Bueno, cuando se haga ya le decimos. A ver si está de vuelta para mí como guía.
This is we're going on the fly. Now these are mostly neuroendoscopists. Half the conference was in English, half in Spanish.
Sí, lo veo. Podemos dejar la cámara, Pachito.
Cualquier persona. Si Álvaro no es disponible, cualquier persona. We'll interview anyone, even the food service guy. Just need experience. Okay, you get to meet Alvaro. Okay. Hola, Álvaro, ¿puede oírme?
Hola, John.
Hola, ¿cómo estás?
Muy bien.
Sí, lo he visto desde México.
Qué bueno.
Sí, yo he visto en México hace menos que un año, más o menos.
Muchas gracias por la transmisión.
Sí, fue más o menos bien. Pero obviamente es un tema con mucho interés en la comunidad de neurocirujanos. Vamos a hablar primero del campo de neuroendoscopía. And by the way, I'm with estoy con otro neurocirujano de Thailand, Warlux. Déjame introducir a Álvaro Córdoba.
Sí.
Warlux, dice hola. Say hello.
Sí.
Ella es un expert pianista, Álvaro.
Qué bueno.
Sí, yo estoy hablando de ti en su guitarra. Y ella también es más que hobby. Es muy bueno. Well, mira, el campo de endoscopía obviamente es más popular. Cuando tú empecé, cuando residente, ¿tú tienes endoscopía cuando empieza entrenando?
Ahora sí, pero cuando yo comencé como residente, no.
No.
Yo comencé en el año 90 y allí recién había comenzado a nivel mundial alguna endoscopía, pero en Uruguay no. Recién comenzamos en el año 2002, después de mucho tiempo. Pero ahí ya comenzaban a haber algunos abordajes diferentes. Todavía no se hacían abordajes incluso de base de cráneo, algo más complicado, era todo muy tradicional. Pero a partir del año 2002 fue cuando comenzamos a realizar las primeras endoscopías. Ahora sí hay los residentes y la posibilidad de poder enseñar y tener entrenamiento es muy común, o sea que se puede lograr.
Ok, en los programas, empieza de principio de endoscopía y usa laboratorios también para mejorar su habilidad física, ¿verdad?
Exacto. Hay programas de entrenamiento ahora mucho más frecuentes en otras especialidades, en la traumatología y la parte de cirugía de columna. Otras especialidades de ortopedia lo hacen, que están aplicando la misma posibilidad de entrenamiento como en cirugía general a la neurocirugía. Entonces, también se hace en los cursos los modelos de entrenamiento y la parte práctica, digamos, con casos clínicos, o sea que en realidad es mucho más completo todavía ahora que hace unos años atrás. Eso es bueno.
Well, tú tienes buen vista de historia de endoscopía. ¿Es más popular cada año? ¿Tú piensas que va a crecer más y más?
Sí, sin duda, ahora es mucho más todavía y se ha expandido sobre todo a lo que es la cirugía de base de cráneo, no solamente la parte ventricular y pediátrica, sino que ya tiene un campo mucho mayor, con tecnología diferente, siempre están mejorando la parte de imagen, sobre todo tratar de poder trabajar con ambas manos, los instrumentos con ambas manos para que sea bimanual. Entonces todo eso es lo que puede ir mejorando con el correr del tiempo, la calidad de 3 dimensiones también. Yo creo que es algo que va a ser necesario y se va a quedar, digamos, como procedimiento junto con todo lo que ya se sabe de la neurocirugía.
Okay, Warlux, Warlux, do you have a question of Dr. Campero, Dr. Córdoba? Warlux, yeah, she's a chief resident. Ella es un residente grande in Thailand. Have you done any endoscopy, Warlux?
My teacher just gave me an opportunities to do the endoscopy case on the pituitary tumor case, and anyway, it's really amazing for me because besides that, I used to do the transcranial approach, and I think it's another field that really interesting. So maybe it's my choice that if I want to further after I finish my training as a surgeon. So for Dr. do you have suggest for the new like trainings like me, like for the starting, what things that I should practice in the neuroendoscopy if I am interested in this field?
Yes, yeah. Where are you working now? In United States?
No, Thailand.
No,
Thailand.
Thailand, perfect. Yeah, yes. Well, actually, the world is much more, it's closer than in the past. So it's possible to learn in a lot of cities and a lot of workshops over the world, perhaps under the International Federation support. And it's possible to see a lot of courses in Europe, in North America, and South America, also in Asia. Very nice. And I think the learning curve is for the young people mainly actually is better than the past. So you must start with an old professor for the first time, and then trying to learn to teach you some things about endoscopy. And you are a very lucky generation because you have a lot of models with the computer actually, and it's possible to train by yourself. So I feel that you are much more lucky than us in the past.
Yeah.
It's possible to learn. Also here in Latin America, in our group and in International Federation, we are ready to collaborate with you and all of the colleagues in Thailand.
Very good. Well, as technology improves, it'll give us more strength to reach more people. So I know you're busy, Alvaro. Thank you very much for the opportunity to televise. Gracias para dejarnos televisar este evento y está abierto la puerta. Cualquier congreso que quiera transmitir, dígame.
Yeah, it's my pleasure. I congratulate to you for the big effort every time in this transmission of the huge events in neurosurgery. You are a great man, really, and thank you so much for all. And for the young lady also, we are ready to collaborate with you.
Okay, thank you, Alvaro. Have a good day. Thank you, Alvaro.
Thank you so much.
Time. Thank you.
Bye-bye.
Bye. Okay, we'll just stay here. Maybe we can meet the food service guy.
Oh.
No, I don't know. I don't know. Hello.
Like you're doing interviewing people who work in this conference?
Well, we'll see if we can talk to anyone else. I don't know if you want to talk to anybody else. So, you do much endoscopy or no, or just a little bit?
I study, still learning. So right now I'm doing mainly the transcranial approach for the brain tumor, and then I think that I work with practice on the transsphenoid more like personally, but we don't have the
Whoop, what happened there? It stopped. Is that my internet? Oh, I think it's yours, Warlocks. Warlocks, are you causing trouble again?
John, ¿me escuchas?
Yeah, muy bien, muy bien. ¿Hay otros médicos que quieran hablar?
No, ya se retiraron todos.
Ok, bien.
Okay.
Gerardo, mucho gusto para sus esfuerzos. Muy bueno. Mejoramiento en el sonido.
Ok.
Tú tienes futuro.
John, me alegro que haya salido todo bien y disculpa por los primeros detalles. Nosotros no hacemos servicio, pero bueno, hicimos lo posible para que saliera todo bien. Me alegro que haya salido bien y que hayas podido transmitirlo en directo.
Sí, estamos aprendiendo, mejorando. Hace equivocaciones, yo no graba algo, pero con tiempo va a mejorar.
Ok. Vale, John, un abrazo grande y estamos en contacto cualquier cosa que necesite.
Ok, cualquier cosa que quiera televisar, dígame.
Ok, Gracias, thank you.
Okay, bye-bye. I didn't introduce you, Warlick. See how rude I am?
I don't know. I don't know much what you say.
Well, he's a technician. They're the key people for these events. It's not the neurosurgeons. The neurosurgeons think they're so damn important. I try not to say to them, hey, I don't want to talk to you. I want to talk to the technician. I want to talk to the technician. They're the important people that make the plugs and connections. And he did a great job. The first day of the conference, you should have seen it. It was terrible. The sound was horrible. You could hardly hear it. And I could hardly hear it. And people would write and saying, oh, the sound is horrible. But you know what? I don't mind making mistakes like that because you learn. You learn. This is not neurosurgery. I mean, a person doesn't die if I make a mistake. I just get better.
Yeah.
By making so many mistakes.
No, but everything went good, right?
Yeah, get some good meat material, like good. Well, that's what in medicine. You know how you've been at conferences, you go, wow, this is a great conference, and it's not filmed a lot of times. I'm not saying film everything, but yeah, I've got a formula. Maybe you can help me, Warlick, because you probably have a future with what we're doing, because it's going to get big. I have to think of a basic plan to present, and I'll give you my feedback, and you can say yes, no. Okay, I have to sketch something general, and I think what I'm going to try to stress to them is that it's just starting. Don't expect miracles quickly. Yeah. And that to build a community takes time. And that for me, and this is just a thought, I could always change, or you could tell me advice. I think we should basically first establish communication with the major neurosurgical centers in China. First step. And the next step is to have a conference with all these places to meet, to talk, so explain the platform, what we're trying to do. Well, you could tell me what you think about it. How would you structure it? Again, I haven't sat down with them, but I imagine they just want to bring live interactive video to the Chinese neurosurgeon. I think that's what they want to do. What do you think? You want to think about it? You can think about it.
I think it's good for me as a new generations. I think for the technologies and the devices with the computer like this is going to be grow in the future. But it's difficult to talk about these technologies with the people in the older generation. Because my teacher, most of them do not believe it yet. Yeah. And they hesitate to do that. And they still stuck in the old system in which they think is good already. So, but I think for China right now, they have open more to the new things, and they want to get that.
Yeah, they want to learn about it. Well, I think neurosurgeons at their heart, they want us to see things get better, and they'll do, I think, anything, including new tech, to get better. If they see it and they see other people doing it and getting better, I think they'll say, hey, I didn't like video, but I think I'm going to try it. I think you're right. It's a slower sell, but I see it amongst older neurosurgeons. Once they know how to do it, it's okay. It's just that first time getting them on the screen to show them it's okay. So.
Yeah, actually, I try to. I have an idea, maybe because from my country there are a few people that present in your channels, but last time that I met Dr. Itichai, in which he from the south of Thailand, and he have a good presentation actually, and I think he's surprised that he met me in this programs too, and I'm sure that he have to speak something like that to his students. maybe your channel will be introduced more.
Sure.
Yeah.
Sure.
Yeah.
Sure. I'd like to get students involved too. That part of I think ideally that we'll have just like a conference in a hospital. You know, you'll have students there that don't talk. You know, most students don't talk. I didn't talk because you're stupid. You know how stupid you are when you're a med student. You don't have nothing. You don't have anything to say. You don't have anything to say other than what time is lunch.
Yes, actually, we do have like not interfaculties, like we have the TerraWise from the Bangkok in every month for the case demonstrations from Bangkok, because I am in the Khon Kaen, in which is in the northeast of Thailand.
Yeah.
So we get the TerraWise every month, and but I think for your system, it's much better than the old system that we have right now.
Okay.
And
well, you're gonna help me implement it. You're gonna help me put it together in Thailand.
Yeah. Last time I talked to my technicians and my teacher, but they still confused that how can it be happen. And last time I opened your channels in the operations room for my teacher, and I told him that I review how to do the neuroendoscopy from that, because last time they have a lecture, Dr. I discussed with I don't remember his name, but he's amazing. So, and I told him that I learned from that, and then he asked me what's that website. So I told him that it's interesting. You can learn it everywhere.
Yeah. And I think there's once we improve communication, we'll improve the art of neuroscience itself. We improve communication amongst physicians, and I think the level of intelligence will come up the more we interact with other people around the world, not just in our community, trading ideas and learning stuff, and not just introducing the new tech that the Chinese are interested in, but introducing the standard of care, good standard of care, neurosurgery, and have the masters teach people in the outlying communities. Do you know what I mean? Like Yuha. I mean, he would love to be televised to the rural areas of the world, to neurosurgeons. They all know his name. They all love him. They know his videos. And there are other neurosurgeons like there's others. But any good neurosurgeon knows how to present all over the world. In Africa, they're very good presenters. So, you know, it's not just one part of the world that, you know, that's it.
Good luck for them to get you first. For China, they're enough to invest, and I think they want to keep their strength to be the center of like this technology.
Yes, it is. Well, that's why it excited me when I let me show you my big website. Neurosurgery wasn't my choice to go into. Let me show you quickly because I got to go in a few minutes. Okay, I'm going to screen share just. Yeah, I got to do a presentation. I'll let you see it before I give it. Okay.
Oh, they're gonna like keep you there for sure.
Okay, let's see. Oh, did I show you? I showed you, right?
I don't
Oh, wait a minute. What I want to show you? Creative Files, Snap. Let's type. Oh, that's types. No, okay. I want to get it here. Okay, do you see this website?
Oh yeah.
Yeah, you've seen it before, right?
No.
Okay, this is all specialties. InternetMedicine.com, where internet means medicine. All specialties. Yeah, it's mine. I built it with the help of Indian programmers. Okay, here, like for example, let me go to cardiology. Let me. Okay, here's the specialties, cardiology. Here. Every specialty has a studio, okay, where the shows take place. This is cardiology, and this is a format I built especially for the, you know, here and there's questions, where they're from, topic review, the forum, mailing list, and stuff like that, request panels. So we specialty as a studio. But the thing is, I didn't have time to do all these specialties. So I ran into a neurosurgeon that liked it. So once I hopefully make it work in neurosurgery, whoa, the world, all specialties. But first, you got to make money.
Okay.
So
Yeah,
that's the first step, is do neurosurgery. I'm sorry?
I think China is the good opportunities for you.
Warlick's, my ears are bad. I'm sorry. Go ahead.
I think China is a good opportunities for you.
Yes, it is. Yes, and I think they may be ready to look at some other technologies, because let me tell you, Warlick, I'm going to a conference after this one in Spain, and they're paying for it. We're going to not only televise, it's a neurointerventional radiology. A lot of neurosurgeons there. You'll be able to see that on January 12th. But they realize that, and at this conference, they have a bunch of Chinese neurosurgeons presenting. I have never seen that myself in my experience. Maybe you have in that part of the world, but I've never seen a Chinese neurosurgeon present at a conference. Have you?
No.
Yeah, and they're going to Spain. And I'll be there with them. I'll know them. I'll know them. So a nice contingent of China will be there. And I'll be there with them, as well as in China. But it's just coincidence, you know. As well as Yuha. Yuha's speaking too. He's big name. Big name.
I hardly know from China.
I'm sorry?
I hardly know the teacher from China.
Yeah.
Yeah.
Well, you know, I'm really not looking forward to leaving a sunny place. It's nice. Computers everywhere, fast internet.
How long are you gonna stay in China?
A month.
What?
A month. A month.
A month?
Yeah.
In the Beijing?
I'm going. Well, actually, I'm going to outside of Beijing. It's Zhengzhou. It's a moderate-sized town, bigger. Not really big like Peking and Shanghai, no, but a good-sized city. But I met the head of this magazine, of online neurosurgery magazine that's supposed to be the biggest in China. I've talked to him, and he wants to meet for a possible collaboration with. I mean, let me show you this website, real quick. He's the editor of it since the year 2012, and they film conferences, neurosurgery. Now, how good is that? Let me share. Let me share this. Hold on here.
I think they have a big plan for you there.
Damn. Okay, you see this? You can't. It doesn't have it translated into English, but it's Chinese. Okay, this is the website. They use WeChat there all the time. They don't use anything else. WeChat. I got to learn that. But this guy wants to collaborate. He's in Shanghai, which is a big convention center, and they tape conferences. They don't show them live though. I'm going to try to tell him, hey, do them live, not recorded. But I don't know. So, anyways, okay, Warlick, thanks for coming.
You're gonna have a great time there, and I think they have a big plan prepared for you there.
Yeah, I think I'm looking at meeting new people. Different. It's a totally different culture. Totally different culture. Totally.
Wait until I finish with the training.
I'm sorry?
I'm stuck with the training. I hardly do things and try to convince other people because I have under control of my teacher.
Yeah.
Yeah, until I finish.
Oh, okay. Well, you got to be patient. But it's I know it's of value. You know it's of value. The others will see eventually, and hey, we'll just wait. That's all. Okay, well, Alex, I gotta run. I gotta go to a meeting. Bye bye.
Okay.
Thanks for coming. Thanks for coming. I'll be sending you ideas.
Okay. Okay.
Okay. Bye bye. And meeting.